Thank you. Well, appreciate the opportunity to be here with such an esteemed panel and lots of good friends. So we'll talk about when CTO PCI should be done. When should you open a CTO? And I think, for better or worse, I only have 8 minutes, and I think the data in this space are somewhat limited, so it should hopefully help me to stay on time. So if you take an idea of when we should open a CTO, we typically think about the patient, but there also are some benefits as a physician as we try to get more physicians who are in the space of helping patients to treat their CTOs. From a patient standpoint, reduction of angina, I think, is the main place where we have data, and we'll review that in detail. You have the potential to increase LV function. You can have the potential to lessen consequences of future ACS, where there's been data which clearly shows if you have a CTO and you have a second ACS event, you're definitely in trouble from a mortality standpoint compared to non-CTO patients. There's the potential to lessen arrhythmia, decrease the use of cabbage, and then decrease nitrate and anti-anginal use, and allow patients to use things like Viagra, which become important for our quality of life as patients often age. From a physician standpoint, I think one of the main parts is, you help patients that are otherwise miserable with angina, and in terms of reasons to get up and go to work in the morning, that's a really satisfying way to spend your day. I think as we grow as CT operators, we definitely see improvement in our PCI skills and devices that we're comfortable with. And as people struggle with PCI volumes, there's a lot of moderate to low volume operators in the country. If you get good at this unique skill set, it actually helps to increase your PCI volume. So currently there's a reasonable amount of controversy around CTO PCI regarding overuse potentially, underuse potentially, and data gaps. And I like the title of Dr. Werner's paper here, 1,000 registries are not worth a randomized trial. Also true for CTO. The problem is there's not a lot of randomized trials in this space, and we'll go through that in a little bit of detail. So effectively, if we think about the rationale for opening CTOs to improve LV function, there were some registry studies early on that suggest there may be a benefit to that. This was looked at in a meaningful way in the EXPLORE trial, where patients coming in with an ST elevation MI were treated for their culprit and then were randomized either to non-culprit CTO or to medical therapy, with the CTO to be treated within a week. And 304 patients were randomized. As you can see here, there was no change in ejection fraction and follow-up. And so one of the thought-provoking things about this is because the LED tends to supply a large amount of myocardium, there was a trend toward there being an improvement in LV ejection fraction in a post-hoc subgroup analysis of LED CTO. So I think that provides fodder for future thought, maybe to inform trials in the future. But at this point, there is at least a kernel of idea that LED patients may have a benefit in terms of LV function recovery, but needs to be validated as a primary endpoint. So with regard to residual burden of CAD, can we help people live longer by fixing their CTO? We know that if patients have a high residual burden of CAD, a high syntax score, after revascularization, they do much worse from a mortality standpoint, as shown here. So the concept then is you could potentially save lives by opening CTOs, and this has not really been looked at in a meaningful way. Several registry studies, this is one of many, have shown that patients that have CTO PCIs that are successful actually tend to live longer than patients that have unsuccessful CTO PCIs. And similarly, if you have an unsuccessful CTO PCI, your hazard of going to cabbage is much higher. There's an attempt to look at clinical outcomes in a study called Decision CTO, which randomized 800 patients to either CTO PCI or optimal medical therapy with follow-up at 5 years. And this showed no difference in a composite MACE of death, MI, stroke, or any repeat revasc, but there were several problems with this study which really were talked about much in the literature and limit interpretation. There wasn't stratification for symptoms or viability or ischemia in the CTO territory. It was a non-inferiority design. There was a lot of crossover, 20%. It was terminated slow for poor enrollment, and therefore was even more underpowered. And it really is tough to show a mortality benefit in a low-risk angina group of elective patients with only under 800 patients in the subset. One thing that was interesting is the per protocol and as treated that sort of accounted for the crossover. There was a trend toward potentially better outcomes with CTO PCI, but as we know as good statisticians, you really can't interpret trials that way. Again, that's fodder for future research potentially. So with regard to improving symptoms, this is one of many meta-analyses or registry studies which have shown that if you look at patients that have a successful CTO PCI versus an unsuccessful, the successful ones have better quality of life, better resolution of angina. This has been recently looked at in a more careful way in EuroCTO, which randomized patients either to CTO PCI or to optimal medical therapy with a 2-to-1 randomization towards PCI. The important part about this trial is all the non-CTO lesions were treated before randomization. In a way which I think is consistent with the registry studies, we see that CTO PCI treated patients had a greater symptom improvement with regard to physical limitation, less angina frequently, frequency, more freedom from angina, and improvement in quality of life. So with that in mind, there have been several CTO PCI patient selection algorithms which have been developed, and we really start to focus on symptoms as the main place where there's data. And in smaller print here is ischemia and LV dysfunction. I'll talk about those in a bit. But if there's an indication based on symptoms for revascularization, and it's a simple CTO PCI in terms of being single vessel or simple with minimal multi-vessel disease, I think it's reasonable to consider CTO PCI for patients. As the complexity of the coronary disease, multi-vessel, left main, diffuse disease goes up, it really becomes reasonable to consider CABG. If a patient's already had a CABG, then I think it's more important that we try to do good work in the CTO PCI space for patients. The place where there's currently uncertainty and where I struggle with our patients is if a patient has a CTO with no to minimal symptoms, but they have a large amount of ischemia, we typically will use a number greater than 10% of their LV mass. We know these patients are at risk from a prognostic standpoint of having future events. And these are cases where we're often asked to open a CTO, but the patients don't have a lot of angina. That's a really important and careful informed consent discussion I have with patients. I'd be interested to hear about the experts on the panel, what their take on that is. And one of the other places I struggle is our heart failure physicians. They see all these beautiful open arteries that we do at the end of cases. And they've started to ask us with some frequency, Kevin, can you open the CTO of my patient who has refractory heart failure, who keeps getting admitted as a way to keep them out of the hospital? They don't have a lot of angina, they have recurrent heart failure. And often these are severely remodeled LVs, which have large diameters. We do always do viability testing in these cases, but it's a case where I struggle because they tend to be some of the harder cases. They're impella cases. The risk of actually doing the PCI is higher than a simple CTO. And again, it's a place where I think we have no data, but there is a potential benefit to patients. And I think anecdotally, many of us have treated these patients with good effect. But I think understanding the risk and benefit in this group is something which would be important to know in the future. So recently, Manos Brolakis spearheaded a really nice initiative which is going to be published in the next several months. It's a white paper which combined the opinion of 101 CTO PCI experts from 50 countries. And the goal is to come up with best practices, at which we arrived at about 7 of them. And I just highlight that the number one common best practice, which starts this list from 101 high-volume CTO operators, that ischemic symptom improvement is a primary indication for CTO PCI. So across 50 countries, we at least have consensus on that. And that's an important thing that I think everyone agrees upon that treats patients in this space. So if you look at the guidelines for CTO PCI, there's certain kernels of information here which I think are important. The US guidelines, talk about CTO PCI is reasonable if there's suitable anatomy and if the operators have appropriate expertise. The ESC guidelines don't really talk about expertise, but they talk about ischemia and or reduction of angina. And more progressive, I think, is the ACC AATS guidelines, which actually don't stratify based on CTO. They treat every blockage the same, and it kind of makes sense. I always struggle with the fact that, if an LED is a 70% versus CTO, there's a little bit of difference in the guidelines with regard to recommending revascularization. In this particular space, I think if the artery is blocked and the patient has an indication, and we can do it safely and effectively, it's reasonable to move forward. So thinking about the barriers to doing this, we know that CTO PCI volume marries with both success and safety. And I think there is currently a barrier to having more physicians who are able to do this and more patients get treated. We know that the median annual number of PCIs performed by operators in the US is 59. So many of our physicians that we work alongside are low volume operators, and there really is an absence of skill set to treat these patients. And we also, as physicians, often underestimate angina, as shown by one of many studies I have here, is that we see patients being undertreated because they're thought not to be symptomatic, but if you actually put them on a treadmill or actually compare their functional status to what you get by history with a Seattle Angina questionnaire, you realize that they're sicker than we realize. So with that in mind, when should CTO PCI be done? It's the integration of the ability to improve quality of life, lessen angina, on top of the operator skill with regard to weighing the risk of a procedure. And one of the things I have to sort of point out is that this is the older AUC criteria, but as we move from patients that have worse heart failure or worse angina and more complex disease, it's been recognized for years these are the patients that have the largest potential benefit, but they also have the highest risk of a procedure. And with improved techniques and now the ability to use hemodynamic support, we have an opportunity to give previously no option patients treatments that they didn't have available 10 years ago, and I think that's an opportunity for the future. So in terms of indications, proper patient selection is really a key aspect of this. The main goal with this data is symptom management. Current uncertainties are low EF, CHF for reduction of heart failure, patients with large ischemic burden with minimal angina. And in the future, there'll be some new trials which will be coming out. Shine CTO is quite nice. It's going to take a sham versus CTO PCI approach with a Seattle Angina score primary endpoint. And I think with regard to undertreatment, I'm solace in the fact that as we have CTO PCI meetings, there's more and more people coming, and our community of operators in this space is growing in terms of numbers, so there'll be more centers where patients can get treatment when it's indicated. Thank you very much.
Right, we have 2 minutes discussion. So how would you, the panel discussion, Stefan, how would you reconcile the clinical, the decision CTO trial versus every other evidence we have from a registry and even Euro CTO? Why the decision CTO was negative versus Euro CTO was positive?
Well, I think it's largely, in my perspective, a beta error. If you look at the data, the mortality data in decision CTO was about 3.4% in the medical group and 1.5 or 1.8% in the PCI arm. It's exactly the same point estimate as you would find in the observational data. But the problem is that when you do a trial and you lump outcomes such as a stroke, which we clearly agree CTO PCI will not reduce, repeat revasc, MIs and everything, you introduce a lot of fuss because we've never shown that CTO PCI would reduce MI. So on the long term, what you have is you do a composite endpoint to reduce the number of events, but then you bias towards the null hypothesis because actually what you wanted to show was a reduction in mortality. And to be able to show a 3.5% to a 1.5 or 1.6% reduction in mortality with an 80% power, you would need 8,000 patients, 4,000 patients in each arm. So I think we got to get over it. We will never have the data to show that CTO PCI can actually save life. It may well be, but we never will have the data.